Hi everybody, this will obviously be a live that's going to be recorded, so rather than just sitting here absolutely silent and mute waiting for people to join, I thought I would just do a bit of an intro, because obviously when people watch this back you don't want the beginning of the video to have 2 or 3 minutes of me just sitting here in silence waiting for Damien to join us. So I'll do all the intros once Damien's on. I'm just going to wait for him to join the live, and then we'll be doing a bit of a Q&A together. I'll start off, and we'll both start off actually with him just kind of introducing himself, and I'll introduce him as well, just so you know who he is and what it's about. But I thought I'd just jump on now before he joins anyway and just say hello to everyone. Gives you a chance. I don't get a time or chance to do lives more than, well, not enough anyway. I definitely would like to do more, so it's nice to see people jumping on. So this is probably a good time for you to say hello anyway as you're on and whilst we're waiting for him. So nice to see people jumping on. Hope you're having a nice weekend, a nice Saturday, and wherever you are. Don't know, where's everyone based? Let me know where you're based. It'd be nice to know what the split is. But that is a vital replanning. I'm not sure what that is. Not sure what that means. But anyway, wait for Damon to come. We've got the live will probably be about 20 minutes or so. So we're going to keep it hopefully quite short and sweet, and then yeah, we can go from there. The context of it is basically about a professional rugby player who Damien operated on, Professor Griffin, who I can see is joined now, so he's probably going to be asking me to share my. I'm hoping, Damien, I am trying to accept you to join, so hopefully it allows you. There we go. Hey, we did it. That's not too bad actually. I thought it was going to be a bit more IT. Um,
Oh, you got that all right, Mehmet.
IT dominated, but we managed it. Thanks for joining.
That's a
Nice
pleasure.
to
How are
come.
you?
I was just thinking it must be probably 3 years since we've done the last one of these, which was, I think it was the first time I'd ever done an Instagram live was
Right.
with you. Like must have been 3 years ago now, probably. Maybe a bit less, but nice to be back.
Yeah,
Nice
it's
to be back. I've
good to
upgraded
see you.
to a microphone, so I've like after 3 years I've upgraded to actually people being able to hear me. But yeah, look, I appreciate your time and thanks for reaching out yesterday. I know we've obviously had a bit of a chat about the situation, but I think people are really going to benefit from this chat and to discuss. It's a really great situation to try and generate a little bit more awareness about what's happened with Tom, your kind of like approach to him. But before we do that, it might be worthwhile you. I'm sure everyone knows who you are, Damien, but it might be worthwhile you kind of introducing yourself as well and just letting people know, I guess, who you are and what you do.
Sure. Thanks, Mehmet. So I'm Damien Griffin. I'm the Professor of Trauma and Orthopaedic Surgery at the University of Warwick, and I work in Warwick and in London. And I always say to my patients, actually, I'm really boring. I just do one thing. I just look after young people, active people with hip problems. And that's why I think this is quite an interesting discussion we're having, because one of the questions that comes up is, well, isn't that doing hip replacements? And the answer to that is definitely not always. And Tom, who has played for England this morning, is an example of someone who's come back after surgery on their hip, in this case, arthroscopic or keyhole surgery. And he's managed to work incredibly hard in his rehab and get back to being able to play at the highest possible level. So that's really exciting. And this is an opportunity for us to talk about how we can try and work out whether that's possible for someone and explore the options for them.
Yeah, definitely. And obviously Nav, who was the physio that was involved, unfortunately he was meant to join, but is travelling. I can't remember where he said he was travelling to, but his flight was delayed, so it'll just be us. But it'd be great. I mean, you touched on it there. Do you want to give a little bit of context around kind of like the player, who he is, what happened, the situation, just to kind of set the scene a little bit? That'd be good for people to kind of have that awareness, as some may not.
So Tom's a Tom Curry is a professional rugby player. He plays for Sale and he plays for England. And he came to see me with his physiotherapist at Sale, Nav, who uh, they were struggling because he couldn't play anymore because of pain in his hip. And that was um, around about December, before Christmas, last Christmas. And we talked about, you know, what's the problem here, how are we going to find that out, and then what options have we got for treating it. And I would say that a lot of the people I see, one of their key problems is that they can't do sport. They want to be able to play sport. Of course, Tom's an extreme example in that he's an international rugby player. Um, but even people who just love playing sport, they go and play a bit of football on Saturday morning, or they like going hiking, or they like running or cycling or playing golf. This is something that's an important part of lots of people's lives. And if, when you're quite young, so Tom's in his 20s, but people in their 20s, sometimes teenagers, sometimes in their 30s or 40s, even a bit older sometimes, people who are perhaps in their 50s or even 60s, but are still active outside doing things all the time. If these people can't do those things anymore, then they get pretty frustrated. And that's when we get interested in how can we help them.
And tell me, with Tom, I think he's a kind of a similar example to many patients that I come across that are at a high level, that have kind of, on one hand, high expectations, and then rightly so on the other hand, a lot of like trepidation for surgery and kind of coming back to an elite level, not necessarily, well, actually both, like at an elite level, at the same level, but also with the same level of performance. I think that's always a concern, that the surgery isn't going to allow them to do that, and there's sometimes a bit of a misperception in regards to um, surgical outcomes potentially not being actually as good as we know that they could be. And I think there's a lot of conversations that I have come around the right individual, the right candidate, the things that will optimize recovery and outcomes and things like that. So I think in Tom's situation, what was the kind of like key presenting, I guess, like factors that determined he was a surgical candidate? And equally, did you find it, what was the kind of the decision that kind of led to that? Were there kind of factors that made you think, you know, he'd be the right person to do it? Like, what was that kind of situation like at that point? Because obviously you said physio was plateaued at that point.
Yeah. So the reason he came to see me was that he'd been trying everything else. So he'd had loads of physiotherapy, load management, anti-inflammatory medication, and typically patients, when they do come and see me, have tried a lot of these things, sometimes for many years and with many different doctors and therapists. So that's what sort of triggers us thinking we've got to take this seriously. In his case, it was stopping him doing his job. Often it's stopping people doing what they love to do. So then we have to take it seriously. And then the first thing is we've got to get to the bottom of what is the diagnosis. And it's not always as straightforward as it might seem. So people don't come with a label that says, I've got a hip problem. They say, I've got pain around here, and they sort of point to their groin and their hip and sometimes their buttock. And so I know you're familiar with this as well, Mehmet. We have to go through a process of talking to the person about what problems they're having, examining them, and then doing some investigations. And for me, that often involves a number of x-rays and scans. And I typically will use normal x-rays, and I'll also use MRI scans to look at the cartilage and the labrum and the ligaments and the muscles in and around their hip. And then I'll use a CT scan to look at the shape of the bones if I have any concerns about that.
Sorry, yeah, go for it.
I was going to say a lot of these people, especially the young athletic person, they often do have something structural about their hip that is causing the problem. It's not just an injury, it's probably something about the way they have grown or the shape of the hip that they've got. And for many of them, and this was the case for Tom, part of the problem is that the ball of their hip is not entirely round. And you and I have talked about this before in your last Instagram live here with me, when we talked about femoroacetabular impingement syndrome, where the ball's not entirely round and it leads the hip to impinge as it rotates. That means that parts of the bone of the thigh bone and just under the ball are rubbing against the edges of the socket. And now if we can catch that early on, and for me the most exciting patient sometimes is someone who's 17, 18, 19 years old, and we're just catching this at the very beginning of the process. If we can catch it early on, then there will be no significant damage to the joint yet, and we can make the ball a perfectly round shape. We can repair any little bit of damage that is there, and we can almost return that person to a completely normal hip. And that's very, very rewarding. So when I see people who are, still at school or in a football academies, young people like that, it's very exciting.
I think, well, I was going to ask you actually on that point, because I think especially from a physio perspective, there's definitely going to be that reluctance, because I guess the flip side to that is like, do we want the younger people having surgery early? And you think, well, actually, it's almost like the understanding around the pathology and the fact that if it's painful and symptomatic, then there might be this potential for it to progress and worsen. And on that, and one of the things I always discuss with patients is we have this spectrum, or even with clinicians, we have like this spectrum of hip health, which is like you have healthy joint with nothing at all, and then in the complete other end of the spectrum you have like the worst level of arthritic change, and there's such a wide array of different variables within that. And considering that, especially with an elite person, I don't know what it was like with Tom, but that's the biggest challenge that I have with an elite person who can't do their job, when they're on that spectrum and it's actually progressed to the point of where you probably think they weren't the most optimized, like with the changes. So if they have like mild arthritic changes or certainly those precursors, how do you, well, maybe for this situation, how did you judge that? How do you make that decision? Because it's almost like that grey area, isn't it? Of like, will they respond well to it? Will they not? How do you make that decision when they're your patients?
So we started from the position that we don't want to do an operation if we can possibly avoid it. And so almost everybody will have some sort of trial of physiotherapy and changing the way they do things, changing the way they move. Tom had that already with Nav before he got to me. So then we're saying, well, is this bad enough that we need to think about surgery? And clearly, if you can't do your job, it is. But if it's something that's very important to you, you want to be able to do it, then you may well think surgery is something you want to consider. Then we want to get clarity as to the diagnosis. So what's the underlying cause of the problem? And just as you say, how bad has it become on that spectrum of, let's call it wear and tear in the joint? And sometimes people have got quite a lot of damage in their joint. And the main concerning damage is where the cartilage that lines the socket of the hip starts to wear thin, or even sometimes to wear away completely. If it's just a matter of changing the shape of the hip or repairing the labrum, a labral tear, then I can almost always do that really very well. But if the cartilage starts to wear away, then that's much more serious. And of course, eventually that becomes so severe that there's no prospect of saving the hip. And now we're starting to talk about needing to have a new hip. So the patients you're speaking about, and this sort of careful analysis of benefit, is to find that group who are bad enough that they need an operation, but not so severe that the damage to the hip has already gone too far. So I'll use scans to do that, and the MRI scan's really helpful there, because the MRI scan can show me the thickness and the health of the cartilage that's lining the socket. Mm-hmm. And if I'm in doubt about that, then I'll use special MRI scans that can map the metabolic health of that cartilage. So there are scans, some of you or your listeners may have heard of T2 scanning or T2 mapping. And there are a number of other techniques, one called degeneric, which are all ways of not just measuring the thickness of the cartilage, but also assessing how healthy it is. And if we're really unsure, sometimes what we'll do is do those scans sequentially. So do a scan now and then do another one in a few months' time. And if we see it's deteriorating, then that would be a prompt towards surgery. But in some cases, and Tom was one of these, and I have to say this is quite frequent in rugby actually, because it's such a high force game. there's quite a bit of damage when you first see the person. And then you've got to think, well, have we got any real prospect of helping with hip preserving surgery, or are we actually in the business of needing to have a new hip? And of course, if it's a professional athlete, there's a third option, which is to retire from playing the sport. Tom was pretty clear with me. He wasn't going to retire, and he didn't want a metal hip, a resurfacing, which is the sort of thing that I will use when we get to the point where there's no alternative. So we were looking for a middle treatment, and that's where we came up with the approach of using arthroscopic surgery, which I use very often, but perhaps he was at the more severe end of the case where I thought it might be reasonable.
It might be worth highlighting the fact that when it was, and the fact that he played today, because obviously I don't know if everyone's going to be aware of that, but obviously I think he returned today for his first game. From what you said, was it 6 months ago, the surgery?
Yeah, so he had his operation in December, so 6 months ago, and he did play for his club at the back end of the season, and now he's been training with the England squad and played with England today. Came off the bench and has played, and I think that's pretty spectacular actually, and is a real testament to what an incredible professional he is, because he's got stuck right into his rehabilitation. And had some really great people working with him on his rehabilitation. Surgery's quite complicated, but that's done in a few hours, and it's the weeks and months of rehabilitation afterwards that are so tremendously important.
Yeah, and that's the thing, I think, and partly probably why I always send everyone to you, is like, I think all of this stuff requires a good collaborative approach. How much do you think an influence kind of, because I want to ask you about the resurfacing as a point, but before we get to that, how much do you think of an influence it is in regards to a patient's mindset, their mental approach, their resilience to kind of, you know, what they've been going through? Because there's such a vast array of our patients with these, like, I guess you could say on paper, like musculoskeletal type pathologies, but have such a, because it takes so long, years and months and years and years and years of having it, that like they have that anxiety and that kind of stress and fear around everything really. And we know that that can also influence outcomes surgically for anything, not just a hip, but you know, most orthopedic procedures. So how do you kind of like see that prevalence in with your patients at a high level? Because I almost find that it's sometimes more because there's so much more at stake, and that's like it's like a fine line, isn't it? Because then you're treating a physical problem, but then you're like, well, actually we've got a person here and pain's quite complicated. And it's interesting, isn't it? Because it's sometimes a bit more complicated than it sounds when you're saying like MRIs and X-rays, but actually it's quite complicated when you've got someone in pain, isn't it?
Yes, so I think partnership is the key word here. Successful treatment is a partnership between the physiotherapist, the surgeon, the patient. For a professional player, often the club doctor and other people in the club as well. Obviously, if it's an international player who's playing for their country, you've often got the country as well, and the people who look after the national squad. So getting everybody working together is really key. But the one person that you can't do without in that partnership is the patient. They've got to be 100% on board with what's going on and part of this. And so a big part of getting ready or thinking about whether to do any surgery and then getting ready to do it is making sure that they really are comfortable with what the diagnosis is, they understand it completely, they understand the pros and cons of any surgical strategy we have, and then they understand what's going to happen afterwards and what their part in that is going to be. And if they're wholly positive going into this, then that is brilliant. If they're not, then we're up against it straight away. Fortunately, I'm very, very lucky that I treat lots of professional and elite athletes because they are always amazingly positive. They just sort of turn up with sometimes terrible injuries, but they just have great confidence. They're certain they're going to come through it and come through the other side. So we work together, and I think we get fantastic results as a result of that, that real sort of commitment and confidence from the player as well.
And with your kind of we'll kind of like touch on a point that you made before, just the kind of, I think it's really important. There are some people that probably listen and think, oh, is it a bit overkill to have like the scans and the CT scans and the 3D motion analysis and all of these things? And one of my biggest concerns are patients who have had surgery elsewhere and trying to understand if it was for the right condition. And I think you mentioned there, like, we have to know what we're dealing with, and sometimes we have things that won't get picked up on x-rays and, you know, MRIs, and, you know, especially things like hip dysplasia and, you know, different acetabular versions and things that might possibly be playing a role from a stability component that the patient's not aware of. So could you just touch on that briefly, just in regards to like when you're doing your imaging workup, around the fact that like we're trying to, I guess, like nullify other potential causes of it? Because you mentioned Tom's was FAI, so like what would, you know, what are the things that clinicians should be aware of, as well as potential other things like dysplasia, etc., that could be there that probably haven't been picked up?
So once we get into talking about surgery, I think we're talking high stakes, because the best possible chance of a great recovery is the first and hopefully the only operation. So I think it's entirely appropriate to commit a lot of time and energy and resource to really thoroughly understanding the problem before we leap into doing something. I think most surgeons feel the same way. Perhaps I'm a little bit extreme. I do really want to get an absolutely clear understanding of it. One of the things I'll often do is to examine the person's hip with them asleep, so that they're completely relaxed and there's no pain and the muscles are completely free. And I can examine their hip under an x-ray machine, so I can actually see how the ball and the socket are working together. And in the case of impingement, I can see that there's a part of the ball which is rubbing irregularly against the socket. So I can see that shape on a scan, but when I do this as an examination under sedation with an x-ray machine, I can actually see the impingement happening live in front of me. And that helps me to work out exactly what is the problem, yes, but also how am I going to go about fixing it. So I can put together a surgical plan before we actually get to the operation in quite a lot of detail. And the imaging helps in that sort of way as well. So, for example, if we see that there's a substantial area of cartilage which is missing, and that was the case for Tom, then what I'm going to do is rebuild that cartilage. And I'm going to have a whole series of options as to how I do that, including putting in grafts and using stem cells to grow new cartilage in situ where it's been damaged. So there might be several different components to what we need to do, and each of those components, whether they be reshaping the bone, repairing the labrum, growing new cartilage, each of those components will have part of the surgical strategy attached to them. And sometimes there are other problems as well. And you mentioned instability. So some people have a ball which is not firmly secure in the center of the socket. One of the reasons for that is a shallow socket or acetabular dysplasia. But there are other reasons to do as well, to do with rotation of the socket, rotation of the femur, the direction the ball is pointing. Sometimes, of course, people have an injury. I've seen quite a lot of people recently who've had hip dislocations, and they can do that playing rugby. I've seen it with people playing football. I've actually seen it with people having non-contact injuries, just coming to a sudden stop and cutting in a different direction. When they do that, they move so quickly that they dislocate their hip. Sometimes it doesn't stay out of joint, it pops back in again, so a subluxation technically. But that sort of history will tell us about problems that we might need to treat in a different way. So someone who's subluxed their hip will have a torn ligamentum teres. They'll have a torn labrum. They may have a fracture of the rim of the acetabulum. So we've really got to get to the bottom of all these potential diagnoses and be prepared to treat any or all of them when we do the operation. And if we make a plan that covers all of these bases, we've got the best chance that it'll be successful.
You make it sound really straightforward, but I think like what often we probably come across isn't as robust an approach from other, and I'm sure there's many surgeons that would follow similar suit, but equally I know firsthand many patients who have had surgery off the back of an X-ray, basic 1.5 MRI, and that was it. And you think there's quite a lot that we don't know yet, and it's a big procedure. I know it doesn't necessarily, I think patients and clinicians see a couple of incisions and think, oh, it's a keyhole. It's a big procedure. It's a complex procedure, and I think there's the recovery.
A lot happens on the inside.
Yeah, and this
It's
is it.
keyhole surgery on the outside, but it's major surgery on the inside.
And I always say to patients that even to get there takes a lot, to distract the joint and to get the portals. I think all of this gets overlooked sometimes, and why the recovery actually has to be so specific and precise. So I'm really thankful that you touched on that. One of the things, and I'll probably, we can wait, I know we still probably keep this to half an hour. Probably the last thing I'll ask you then is, you mentioned about the resurfacing as a later stage intervention potentially for those who don't respond to arthroscopy, and you're trying to kind of weigh up the decision, arthroplasty or total arthroplasty or resurfacing. Tell me your pros and cons of resurfacing, because I know there are some, and I think it'd be good for people to know, because it's always the patients who are active and want to stay more active that go and research about resurfacing, and it's not everyone's option. So you from your perspective, what are the pros, what are the cons for resurfacing?
Sure. So just before I do that, one thing I would say is we want to try and avoid a situation where we do an arthroscopy and it doesn't work, and then we have to do a resurfacing. Of course, that happens sometimes, but ideally we can make a judgment correctly up front as to whether the arthroscopy is going to be successful or whether we need to go straight to a resurfacing. And that's often based on just how bad the cartilage damage is. And I think that was the interesting thing about Tom, that it felt to me as if he was on the boundary. It looks like it maybe wasn't going to work as an arthroscopy, and maybe we needed to go to a resurfacing, but he was pretty clear, no, don't want to do that, let's keep my own hip. So pros and cons of resurfacing. So if we're in a situation where we need to do an operation, we're going to have to put some sort of new hip in, then we've got essentially two options. One is a total hip replacement and the other is a resurfacing. And the resurfacing came to fame, I guess, recently because of Andy Murray having one. Total hip replacement, everybody's familiar with, because pretty much everybody knows someone who's had a hip replacement, usually in their family. So both operations are really, really good. So they're fantastically good at treating wear and tear, arthritic damage to hip joints. I think that if you are younger, and I'll sort of define that a bit in a minute, but if you're younger and if you want to play sport which requires a big range of movement or is likely to involve impact, contact, then a resurfacing is more attractive. The reason for that is that the younger, resurfacing is more attractive because if you have to redo it, then you can redo it to a total hip replacement, and it's nearly as good as if you'd started the total hip replacement from scratch. So sometimes people think, well, a resurfacing is a little bit like doing an operation now, and that puts off the need for the total hip replacement for 20 or 30 years or something of that order. So that's why younger is more, the resurfacing is more attractive. And then the point about sport, and particularly contact sport, is that there's a little bit of evidence that people who have a resurfacing find that their hip works a bit better at the top end of performance. So for example, if you're running, maybe your hip works a bit better. Because the ball of the hip is the same size as your natural hip, rather than a total hip replacement where the ball is much smaller, it may be the mechanics of it are a bit more normal. And also, if you're going to get hit, so if you're a rugby player, for example, if you're going to get hit and knocked about, then there's a real risk of dislocating a total hip replacement. There's still a risk of that happening with a resurfacing, but because the ball is so much bigger in a bigger socket, it sits in the socket deeper, it's less likely to come out. So people who really want to get back to doing sport and they're younger, they're the ones that I sort of talk to about resurfacing. There's a little bit of a rider on that, which is that at the moment with metal resurfacing, we don't think it's appropriate to treat women with that, which is not a sexist comment at all. It's simply that we have found that women are more likely to get problems with the metal on metal bearing than is the case with men. So for most surgeons like me at the moment, resurfacing is only used for young men and not for young women. That's likely to change in the next year or so as we start to use resurfacing that's made of ceramic, where I think that option will come up, but that's a whole another conversation. Then older people, so if you're an older person who is not going to be fantastically active, I mean, they might be active, they might want to go walking or running or cycling or swimming, but they're not going to play hard contact sport. And because they're older, the issue about how long their joint is going to last is a bit less of a concern, because a really good modern total hip replacement has got a 90% chance of lasting 30 years or more. So if you've got an older person who's not going to be quite so harshly active, then a total hip replacement is a simpler and perhaps a little bit more safe operation, in the sense that there's no risk of a metal on metal problem. Now, I think among my patients, the sort of crossover point comes usually around the 50s. So someone who's younger than 50, we're often having a pretty serious conversation about resurfacing. And someone who's in their later 50s, I often use my age as the cutoff. So I'm 58. So I say, for me, I think I'd have a total hip replacement.
But would you save the because I think this would be good for people to know, like, so for the resurfacing, what about that recreational weekend warrior athlete that is super active, that likes to go for a run, that likes to wants to do a half marathon, that doesn't want to necessarily do contact sport but wants to stay active, but it comes to you and says, I want a resurfacing, I've looked at that, or we're having that discussion, knowing that the longevity and actually robustness of an arthroplasty could be quite good anyway, and then knowing the longevity of the
I get lots of those people. They're not professional rugby players. They're people who like to go out and go running or go cycling. They do triathlons. A guy recently did a lot of hill running. So those people, they come to me sometimes, they say, I prefer the idea of a resurfacing. It's more like a natural hip. And once we've had a good talk about it and weighed up the pros and cons, we very often will decide that's what we're going to do. The way I do a resurfacing is a little bit, requires a little bit more investment from the patient, in the sense that these young people, so let's say we've got someone who's 45 with this problem, they probably have a hip that's not really the right shape. That's why it's worn out in their 40s. If they had a normally shaped hip, then it probably would still be fine when they're 45. But it's worn out because it wasn't really the right shape. So they had the same sort of problem that Tom did, but it progressed and they got to clear arthritis. So I think we've got to change that shape. We've got to make it a really good shape. There's no point in just resurfacing an abnormally shaped hip. So I will completely reshape their hip at the same time as doing the resurfacing. And that means it's a bit of a bigger operation. It's a slightly longer operation. And they'll need to use crutches for a few weeks afterwards. So by the time they get to 6 weeks out, it's made no difference. All of that is in the past, and they'll be looking forward to having a hip that they don't even know they've had it replaced. It's fantastic, and they have no pain. But it just is a bit more investment for them at the beginning. But I have lots of people who come to me and they say, I'd like you to repair my hip. We look at it. After we've done all those scans and everything, we say, it's not really repairable. The damage is too bad. And so then we start having a conversation about resurfacing, and we might settle on doing that.
Damien, I thought this was going to happen. This is what happens anytime we talk or anytime we meet. We kind of have this. We think, oh, we'll have a 10-minute chat, 50 minutes, and it just goes on and on. This is the problem. If you put two people passionate about something in a room and end up talking, I could easily do this all day. So, but I know we've said we'll try and keep it short and sweet today. What I'd suggest is anyone who's watching this video, comment any questions, because I've seen some people asking questions and stuff. What I suggest is anyone watching this live or watching the recording back, comment with your question. No doubt there will be a multitude of questions that come in, and then maybe we can have another half an hour catch up another time, and we can go over some of the questions. Sure. And just segue it into another catch up based on what people have asked. But look, massive congrats to you and the team. I think we've had a great discussion, but you know, the fundamental thing here is you've got an England rugby player back playing rugby today, which is outstanding. So credit to you and the team and to him. And I think the more we show and spread an awareness that can happen, the better, and the less people are scared of surgery for the right person at the right time, in the right situation, right context. Like, everything has to be right. But when it is right, it can be so successful. And I think people need to be aware of that and not think of arthroscopy for FAI syndrome as this kind of end of the road, like last ditch attempt for something. So actually it's something can be the most effective, but you just have to it's not the first port of call, but also for some can be the right answers. I think people need to be aware of that. Appreciate your time, Damien. But like I said, I could stay. I've got the kids downstairs. I could stay here all day, but my wife will probably be wondering why I've left them on their own for about 5 hours. So I'll best shoot off. But thanks for your time, and well done again to you and Nav. And Nav, if you're watching this, shame that you've not been able to catch on, but no doubt you're probably sunning yourself up somewhere. I don't know where I think it was Greece or something. So maybe we'll do it again next time.
Maybe we can get him in next time.
Exactly. Yeah, that's what I was thinking. We'll do more rehab approach. Yeah, for sure. I think that'd be great.
I mean, the rehab side of it is so important. It'd be fantastic.
Arguably, probably even more important. No, I'm joking. But no, I know what you mean. So maybe we'll have a chat anyway. We'll arrange a second one, and maybe we can put that spin on it. But yeah, thank you so much, and well done. It's been really good to hear a good story. And thanks to everyone for joining in. Lots of good questions, and we'll catch up soon. All right.
Bye-bye.
Thanks, Damien. See you later.